Yeah, dear ladies and gentlemen, dear participants, Chris, thank you very much for the great introduction. We will need it, and I will come back to some of those parts he explained already. So let's move forward. So conflict of interest, there are always some things to mention. We are presenting now on behalf of a research group called Forced Research Group. This was a joint cooperation between Maastricht, Robert van Koeveringe, Kevin Rademakers, and with me. We received the Detrusor European Grant Foundation. There was a lot of money. We could employ Kevin Rademakers, and the majority of research I'm showing you was created with this money that provided for us in this research grant. So there are some objectives in this lecture, and I would like you to learn about the definition of Detrusor Underactivity, to distinguish between Detrusor Underactivity and bladder outlet obstruction in men, to know the invasive and non-invasive tests to diagnose Detrusor Underactivity in men, and to become aware of the clinical value of Detrusor Underactivity. And as you can see, I'm talking about Detrusor Underactivity, and I will give you the rationale why I'm talking not about underactive bladder. Underactive bladder is a clinical diagnosis, Detrusor Underactivity, the urodynamic diagnosis. In general, when you have a person who cannot void adequately, so he has increased post-void residual urine, decreased voiding efficiency, or decreased urinary flow rate, there are only 3 reasons why he cannot adequately void. It is Detrusor Underactivity, it's bladder outlet obstruction, and dysfunctional voiding is a sort of functional bladder outlet obstruction. These are the 3 reasons that can exist, and of course the overlap between the 3 components. When you have adult men, it's rather untypical to have dysfunctional voiding, so the main components are Detrusor Underactivity and bladder outlet obstruction. And as Richard Turner Warwick already mentioned, you cannot distinguish between the symptoms of Detrusor Underactivity and bladder outlet obstruction, besides this latest publication from Paul Abrams and Andrew Gammy that was showing the opposite. So when we're talking about Detrusor Underactivity, we're talking about a urodynamic diagnosis. It has been defined by the International Continence Society already in the year 2002, and I think there's no major change in the most current classification that was discussed during this ICS meeting. It is a contraction of reduced strength and or duration resulting in prolonged bladder emptying and or failure to achieve complete bladder emptying within a normal time span. This is the original definition of Detrusor Underactivity. So therefore it is a urodynamic diagnosis characterized by decreased detrusor pressure and decreased urinary flow rate. And when I teach my residents, I like to show exactly that image that I'm showing you here right now. So this is the normal situation. You have the intravesical pressure, intra-abdominal pressure. This is the detrusor pressure, urinary flow, and EMG. You are looking now for the relation of pressure and flow. Here is the pressure of the detrusor, so it's a low pressure and a high flow. That's normal. When you have somebody with bladder outlet obstruction, he has a high pressure during voiding and a low flow. And Detrusor Underactivity is a low pressure and a low flow. So these are the urodynamic diagnosis of bladder outlet obstruction and Detrusor Underactivity. Always bear in mind, these are extremes, so you can see the difference. So there are all types of measures in between these extremes. Again, what's happening during voiding? Normal voiding, you have the detrusor or the bladder wall, the prostatic urethra and the prostate and the pelvic floor. For Detrusor Underactivity, you have a low pressure and a low flow. Bladder outlet obstruction, a high pressure and a low flow, most probably caused by bladder outlet obstruction, benign prostatic obstruction. And we have also the combination of bladder outlet obstruction and Detrusor Underactivity, but now it's becoming difficult. So we have good thresholds, specifically with bladder outlet obstruction. We have poor threshold values available in the literature about Detrusor underactivity, and we have no threshold value in the combination of both statuses. So the normal voiding with a complete bladder emptying within a normal time span is possible when a man has adequate balance between bladder outlet resistance and contractility. So it's the driving force of the detrusor against the resistance of the urethra or pelvic floor, prostate. And when this is a good balance, we can void within a normal time span and completely. Abnormal voiding occurs when men have an increased bladder outlet resistance, or they have a decreased detrusor contractility. And one component may compensate for the other. For example, you have a patient with severe bladder outlet obstruction, and it may compensate by increased contractility, so it's now compensated. But if you have bladder outlet obstruction, so high resistance, but you have a poor detrusor contraction, so a poor driving force, there will be most probably post-void residual urine and maybe even urinary retention. Chris Chappell has already mentioned the epidemiology, and I'm specifically mentioning the epidemiology of male data. What we know, Detrusor underactivity in sort of epidemiological trials are up to 40% in men aged 65 years or older. We know that it's up to 48% in patients aged 70 years or older. What we know from very old people, approximately 2/3 of incontinent, institutionalized elderly patients have Detrusor underactivity. Bladder outlet obstruction is clearly defined, has been well investigated, and all the major trials show in about 50 to 60% of the unselected patient population there is at least a sort of degree of bladder outlet obstruction. And again, no information in patients with Detrusor underactivity and bladder outlet obstruction, so this is the combination. So we are now looking for the diagnosis. How can you practically make the diagnosis at home? We have many existing parameters, and we have the standard diagnostic test, and this is invasive pressure flow data, though these are urodynamics. It may be even possible to develop a screening tool with non-invasive parameters to have at least extremes form of Detrusor underactivity, or to have a good imagination who could be a candidate of Detrusor underactivity. So what are the invasive indicators of Detrusor underactivity? And this is exactly the same image. It comes from an overview article by Dr. Osman, and Chris Chappell was the co-author, or I think the last author of this article. This is a review article, and you have all these parameters that Chris already explained to you here. These are the parameters, and I will point out some of those parameters which we certainly use in clinical practice on a daily basis. What we used to do in Hanover, Germany, we were using the Schäfer Nomogram. And the Schäfer Nomogram has here the voiding plot. It's a linear pure. It is the point P-dat max and the minimal voiding pressure. And this line is the linearized pure. The length of the linear pure describes the contraction, the contractility, contraction strength. And when it's high, it's in a normal position. If it's higher, then it's strong or very strong. But if it's lower, then it's weak or very weak. So we can judge contractility according to different types of bladder outlet obstruction. And bladder outlet obstruction are Schäfer grades 0, 1, 2, 3, 4, 5, and 6. So we have a nomogram, the Schäfer nomogram, that provides information about bladder outlet obstruction and categories about contraction strength. The next parameter we may want to use is bladder contractility index, like Chris has already mentioned. And I'm pointing out the problem now. Bladder contractility index is the estimation of the lin pure of the Schäfer nomogram. And it can be calculated as P-dat Qmax plus 5 times Qmax. And the problem appears now that a patient with Detrusor underactivity and incomplete voiding, he may strain. And straining leads to an increased Qmax. And because this Qmax is artificially high, you multiply it with 5. And there may be the problem with calculation of bladder contractility index. The alternative is calculation of Wmax, that's the maximum Watts factor. Some urodynamic machines calculate it automatically. So my machine I use in Hanover, that's an Andromeda machine, calculated automatically. It's a parameter that appears on the computer in the evaluation form. And you can see here an example of patients which we prospectively investigated and collected in our urodynamic database. And you can see in men that these parameters, bladder contractility index and Watt factor, the maximum Watt factor, which has a very complicated formula, they increase with bladder outlet resistance. So now we have a problem, because when we are now choosing threshold values, we want one value that we remember, like bladder contractility index below 100, and this is something we define as Detrusor Underactivity. Now we have done this in our database, and you can see here is the line 100, and everybody under this line would be Detrusor Underactive. So these are all patients with Schäfer grade 0 and Schäfer grade 1. So all the non-obstructives would be Detrusor Underactive. This is highly unlikely, isn't it? And the great majority of Schäfer grade 2 is also Detrusor Underactive. When we are now looking for the threshold value for Wmax, and there's a threshold value 7 or 7.5 or 10 watt per square meter suggested, and you can see in the same population almost nobody would be Detrusor Underactive. So now we have a problem, which one is true? Are they all underactive? Or is nobody underactive? We actually don't know. So we have to find a correlation between bladder outlet resistance and contractility. We have to find the balance. And we were suggesting in one publication to use a new nomogram, which is called Maastricht-Hannover nomogram, because Roman van Koeverien is from Maastricht, I'm from Hannover, so we gave the Maastricht-Hannover nomogram. So we were defining now threshold values. What we did, we had an analysis of a urodynamic database with a total of 822 patients, treatment-naive men with LUTS, and these patients were aged 40 years or older. We excluded certain diseases like prostate cancer, neurological diseases. These were the so-called male LUTS patients or BPH patients, clinically defined. Then, first we plotted each patient with Wmax according to BOI. So we took BOI together with Wmax and plotted all these 822 patients here in this plot. Then we calculated the percentiles, the 10th, 25th, 50th, 75th, and 90th percentile. This is what we did. And then we were comparing these groups in between these areas. And we came out that everything under the 25th percentile is significantly different compared to the other percentiles above. Now I'm showing you the data. You see these are the patients below the 25th percentile. These are the ones between 25 and 50, so one group above. And you can see significant differences in age, significant differences in post-void residual urine, differences in voiding efficiency, systematic bladder capacity in Wmax, but not in bladder contractility index. And these exactly are the clinical parameters which we think are associated with Detrusor Underactivity. So, we obviously have a problem with the adult population because there is aging. And we have done an epidemiological study in Germany, and we determined all these values, and we looked for normal healthy people, no drugs, no other diseases, no operations whatsoever. We defined a normal population. From the 28,000 people we evaluated, about 2,000 were normals. And we defined, according to the age group, the Qmax. So what is a normal Qmax for somebody who is healthy? Between 50 and 55, 56 to 60, and so on until 75 years or older, and the voided volume on PVR. You can see that with aging there's a decrease in maximum urinary flow rate, there is a decrease in voided volume, and there's a slight increase in post-void residual urine. So what's happening with aging? And now we are using the nomogram, which I just introduced to you. Again, here is Wmax against bladder outlet obstruction index. A normal patient can void completely, no post-void residual urine, a low grade of bladder outlet resistance, so he's starting here maybe in the age of 20, and when he's becoming old, let's say 80, he develops obstruction and Detrusor underactivity. So he will go in this area and develop post-void residual urine, because here is very likely in the gray area that these are Detrusor underactive patients, in this case with aging. So what is now the value of our treatment? And Chris has mentioned some of those operations. And this is now like a intellectual practice, let's say it that way. So men with bladder outlet obstruction and with normal or low contractility receives a TURP. So he is an obstructive patient, bladder outlet obstruction index 80, that's clearly obstructed. And when he receives a TURP, he will move from a very low percentile to a normal percentile. For example, this patient is moving from the percentile between 25 and 50 to the 75 and 90 percentile. It's very likely this patient will void better. When he had an incomplete voiding, then he will become complete. So the balance between contractility and resistance is better. And the same even happens with this patient. So he has Detrusor underactivity, you resect him, and he will move into a favorable area where he most likely can void. But what's happening if a resident is now resecting and he cannot do the operation well, and he's resecting incomplete? So if you're not resecting well, you are remaining with a bladder outlet obstruction, and the patient will stay symptomatic, will stay with his post-void residual urine. So this is a theoretical basis what's going to happen. So when there's a patient, a man without bladder outlet obstruction, so here is a BOI of 20, 25, 30, so he's not clearly obstructed, with Detrusor underactivity. And what's happening when this patient is now receiving a TURP? The reduction of BOO is low, so he will not significantly move to the left side. And this patient will more probably will be the same than before, and it's very likely that this patient stays rather identical compared to the preoperative situation, at least from the likelihood ratio. This is real data. This is now real patient data. I'm going back. This is theoretical calculation. This is real patient data. And what you see now is rather amazing. You can see three different types of patients. You see the blue patients. These are patients with a successful outcome. These are real patients before and after TURP. And this patient in blue is a treatment success. No symptoms whatsoever, no post-void residual, and he is healed, he's fine. This patient comes from this area, he has been resected, and he's fine. This patient comes from this area, he's fine. But this patient, or these four patients, coming from a Detrusor underactivity area, resected, so there is a reduced bladder outlet obstruction, they remain with post-void residual urine and LUTS. So these patients are non-responders, and the blue patients are responders. And there's a yellow line. I don't know if you can see the yellow line. This is like partial mix. He's reduced in symptoms, but still has a little bit post-void residual urine. So he's right at the edge. So what we can do now, or what we can see, is rather amazing. You don't only reduce bladder outlet resistance. You don't only go from right to left with resection, but you are also moving downwards. So there seems to be a balance between Detrusor contractility and bladder outlet resistance Immediately after the operations, patient with Detrusor Underactivity is very likely to void, but in the long term, as Chris Chappell has told you in the famous Thomas studies, the patient is not very likely to void. And this is summarized in this slide. So what's emptying, the fate of bladder emptying post-void residual voiding associated with bladder contractility LUTS have been determined in long-term studies. So these are the two Thomas publications Chris has already mentioned. In the clinical and aerodynamic evaluation at baseline and at least at 10 years were done. In men treated with TURP, all parameters, and I'm talking about these parameters, remained unchanged after median follow-up of 14.5 plus minus 3.2 years. The patients who did not receive treatment remained with Detrusor Underactivity. Their symptoms did not change as well. And when you now compare the treated and untreated group, the bladder outlet obstruction index decreased in TURP group. This is not surprising. But the patients with TURP did worse because they had significantly higher post-void residuals. The voiding efficiency was significantly lower and more men had chronic retention. So the men who received TURP did even worse than the patients who were handled by conservative management, watchful waiting. The conclusion of the article was TURP is an inadequate treatment for Detrusor Underactivity, and in doubt you should do a computer urodynamic investigation if you have a patient you would like to resect and it's doubtful. And in the EU guidelines, and I was one of the committee members, we recommended that a patient older than 80 years of age should have a urodynamic investigation before TURP, just to exclude Detrusor Underactivity. So what's happening with an alpha blocker? The alpha blocker reduces bladder outlet obstruction index by 16%. The German meta-analysis we did for the guidelines. 16% reduction of BOI. So what's going to happen? A patient here with Detrusor Underactivity and obstruction will not move in a favorable area. And the patient without obstruction, he may move into a favorable area. What's happening with antimuscarinics, and this may be an explanation why some patients go into retention and some patients don't go into retention. What does an antimuscarinic do? There's a reduction of bladder outlet obstruction index by 12% and a reduction by Wmax of about 20%. This is literature data, so I was plotting it here in the nomogram again. Here we have the patient with obstruction, and he's going down 20%, he's moving a little bit to the left side, and nothing is going to happen. But this patient who's at the edge of Detrusor Underactivity, if he received antimuscarinics, he's likely to develop post-void residual urine or maybe even develop retention. We have now validated our nomogram with data with sacral neuromodulation. As you know, Maastricht, Philip van Kerrebroek, Roman van Koeveringe, world biggest sacral neuromodulation center. And we have looked for the patients, for the male patients, with Detrusor Underactivity on clinical basis, and we looked for the preoperative urodynamic investigation. I have to limit all patients with retention who could not void, we cannot use because we cannot plot them in nomogram. So these were patients who could still void. So these are men with impaired bladder emptying, post-void residual, and the need for clean intermittent catheterization. All received sacral neuromodulation, and these are the patients who showed up in the area between the 10th and the 25th percentile. It's just showing us that the clinical judgment of the patient correlates quite well with our nomogram. And these were the patients who were below the 10th percentile, and you have here several or two different types of patients. The circle, these are the patients who had Detrusor Underactivity, were treated and were treatment success and did not need clean intermittent catheterization anymore after sacral neuromodulation. The other one, these are the patients who had Detrusor Underactivity and were treatment non-responders, so they could void but still had high post-void residuals and still needed clean intermittent catheterization. And when we looked here for the areas if a patient was preoperatively between the 10th and the 25th percentile, he had a treatment success of 86%, and when they were below the 10th percentile, they had a treatment success of only 20%. This, by the way, is the first, let's say, nomogram, first information about a patient, about a man, before sacral neuromodulation. We can now predict the treatment outcome in patients with sacral neuromodulation due to Detrusor Underactivity. I quickly pass through these non-invasive parameters, just want to point out some specific things. Symptoms, we've just heard from Chris Schäfer. This was one of the publications. Although it's previously told for decades there is no symptom that's really predictive of Detrusor Underactivity. The working group of Andrew Gemmey and Paul Abrams, they found some of those symptoms after a big analysis of 28,000 something traces, so they could predict that a certain set of symptoms are predictive of Detrusor Underactivity. If you have to weight the symptoms, this is still open for discussion. There's going to be a questionnaire out soon, I think. I participated in this prospective study to evaluate this questionnaire. I have not seen the results yet. But what I would like to show you is a non-invasive test with Detrusor, with ultrasound Detrusor Wall Thickness measurement. This is a measurement tool which we have developed in the past to diagnose bladder outlet obstruction, because if there is obstruction, there's a compensation mechanism on the level of the detrusor, that the detrusor becomes stronger and also thicker. It is well known and also accepted that an enlarged detrusor wall or bladder wall is indicated for bladder outlet obstruction, and you can use it in a prospective investigation. The detrusor wall thickness that is higher than 2 millimeters in a filling of more than 250 milliliters, it is rather predictive of a bladder outlet obstruction index. Positive predictive value is about 80, is about 96%, so it tells you something. And we evaluated now what is the value in Detrusor Underactivity. As already published in the year 2002, you can see one of these horrible images we delivered at that time, that here you have a detrusor wall, that's the black bar between the white lines, of 3.1 millimeters, so it's greater than 2.0, so this is bladder outlet obstruction. But we also had symptomatic patients with a very thin detrusor wall, it's 0.8 millimeters. And we wanted to find out if we can measure Detrusor Underactivity with ultrasound Detrusor Wall Thickness measurement. So what we do? We reanalyzed this old database where we started a prospective investigation to show that a bladder outlet obstruction is associated with thickening. We re-evaluated this and we sent a program over it. It's called CART analysis. It's a multifactorial, a multivariate analysis. And what we found out, that in the group of Detrusor Underactivity, which we defined clinically by exclusion. So a patient with post-void residual urine, without urodynamic obstruction and without dysfunction avoiding, but still with post-void residual, must have Detrusor Underactivity, right? So we classified this as a clinical diagnosis. And we had UAB, so this was our clinical diagnosis, and no UAB, and you see significant difference, bladder capacity, Detrusor wall thickness, post-void residual volume, and all these parameters. So now we put everything in the computer, and the computer is asked to find the tests and the thresholds to predict our clinical diagnosis of Detrusor Underactivity. And what did the computer do? We had 143 patients, and the computer chose by itself first order Detrusor wall thickness and the threshold smaller or equal 1.23 millimeters. Again, more than 2 millimeters is obstruction, and he chose less than 1.23 millimeters. So this is the first one. He could already predict 78% of the patients with our clinical diagnosis of Detrusor Underactivity. And if he was adding a bladder capacity that came from the Euroflow data, he could predict all patients with detrusor underactivity. So the combination of a thin detrusor wall and a large bladder capacity, or thin detrusor wall thickness smaller than 1.23 millimeters, and a large capacity greater than 445 milliliters, this is showing you detrusor underactivity. We calculated the diagnostic values, and you can see that here are still some patients with detrusor underactivity inside, and we can see a sensitivity is quite low, but a specificity of 100%, and important positive predictive value of 100%. So if you have a patient with large capacity, small detrusor, then it's detrusor underactivity, and the likelihood ratio of positive test result is really high, 42. It should be more than 10 to be a good test. What is now the difference between these detrusor underactivity and these detrusor underactivity patients? These detrusor underactivity patients are more the extreme patient. There is a significantly lower W max value. So last slide, and I will come to the end now. The balance between the bladder outlet resistance and contractile function in the bladder is sufficient for voiding, is responsible for sufficient voiding. Detrusor underactivity is a urodynamic diagnosis, but threshold values have to be separately defined for different BO grades. So there's not a single threshold value for all patients, at least not for all male patients. This new nomogram we call Maastricht and Hanover nomogram defines the threshold values for all obstruction grade. So the value BOI and the W max data points below the 25th percentile indicate detrusor underactivity. The nomogram can predict the outcome of treatment when we are talking about sacral neuromodulation, most probably TURP, and non-invasive parameters are potentially able to replace the computer urodynamic evaluation in clinical practice, but until now only detrusor wall thickness in combination of bladder capacity has been evaluated. And again, the work is still in progress. We are at the very beginning, we are continuing. So this is now an update, what we've done in the last 18 months. And this is brand new. Most articles have not been published, are submitted or published online. Thank you very much.